This talk will cover lung cancer, lung injuries, and respiratory failure. Lung cancer is the leading cause of cancer death in the United States for both men and women. It is usually associated with smoking, can be associated with secondhand smoke, can also be associated with chemical exposure such as asbestos and radon gas. And unfortunately, even people with no risk factors can get lung cancer, but it's rare. Usually there is some causative factor that they can find. It originates in the respiratory tract epithelium and is classified by the cell type. There are 4 major cell types of lung cancer. Lung cancer is not one disease, but it is 4 different diseases that have different characteristics, grow differently, and are treated differently. Small cell cancer grows rapidly, and it often has metastasized by the time of diagnosis. It is usually caused by smoking. The tumors are often central, and so it's difficult to do surgery for these, and there is a poor prognosis for this disease. This makes up about 20% of all lung cancers that are diagnosed. Large cell lung cancer is rapidly growing, and it can occur anywhere in the lung. It also has early mets, and it also has a poor prognosis. Um, Adenocarcinoma occurs more often in women. It appears in the peripheral lung fields and is slower growing, but unfortunately, it's often not diagnosed until metastases appear. It is less linked with smoking than some of the other kinds of cancer, of lung cancer. Squamous cell is the most common non-small cell cancer. It is usually in the bronchi. It metastasizes late. It's caused by smoking, and it actually has a better prognosis than any of the rest of them. Um, so if you look at the slide, the cell types are, it's either small cell, which is 20%, or non-small cell, which is 80%. And then the other ones that I just described are part of the non-small cell cell type. The single most important way to prevent lung cancer is to stop smoking. The American Cancer Society publishes the common lung cancer signs and symptoms. And the signs and symptoms really can depend on the location of the tumor. As you recall, some of them are in the more proximal bronchi, some of them are out in the lung parenchyma, and so really it just depends on where the tumor is located. Many people ignore the symptoms as they are also common with other smoking related issues such as COPD. So that's why it's not picked up as quickly, and oftentimes the disease has metastasized before it's diagnosed. So from the American Cancer Society, some signs and symptoms for people to look out for are a cough that does not go away or gets worse. Real easy to confuse that with just garden variety COPD. Coughing out bloody or rust-colored sputum. Chest pain that is often worse with deep breathing, coughing, or laughing. Again, could be pleurisy after pneumonia from a COPD, that kind of stuff. Hoarseness, loss of appetite, and unexplained weight loss. Cancer is notorious for unexplained weight loss. But then COPD uses up a lot of calories. People don't eat, they lose weight as well. Shortness of breath, that's common in all chronic lung illness. Feeling tired or weak, that is common in all chronic lung illness. Infections such as bronchitis and pneumonia that won't go away or keep coming back. And that's often when this is diagnosed, is as you've been in again and again and again, and then all of a sudden on a chest x-ray, they'll see a mass. And then new onset of wheezing, that would happen because you've got a tumor that's growing in a larger bronchus and obstructing airflow. There are a lot of different and varied complications for lung cancer. About half of lung cancer patients get a pleural effusion, either from irritation or obstruction of the lymph or venous drainage. We talked about pleural effusions in restrictive lung disease. You can get what they call superior vena cava syndrome. That happens when a tumor obstructs the superior vena cava and obstructs blood flow. This causes jugular venous distension, edema in the head, neck, and chest. And when this happens, they usually try to shrink the tumor with radiation because it can be very dangerous. There are tumors that produce hormones that mimic the body's own hormones. For instance, you can get SIADH, which is the syndrome of inappropriate secretion of ADH from increased ADH. You can get Cushing's from increased ACTH, and you can get increased calcium from a parathyroid-like hormone that happens. And that's something that you see quite a bit. You can also get atelectasis when the tumor growth prevents ventilation and the alveoli distal to the tumor collapse. And of course, there's a high rate of pneumonia, higher risk, of pneumonia in people with lung cancer. Not only from the disease in the tumor, but if they are getting chemo or radiation, their immune system is suppressed. Metastasis for lung cancer, you want to remember BLAB, B-L-A-B, brain, liver, and you could also do the opposite lung or lymph, but it's mostly brain, liver, adrenal, and bone. Those are the big sites for lung cancer mets. Usually, you'll first see a tumor on a chest x-ray. Then oftentimes they will get a CT scan to get a different view of it, and then a PET scan. So a PET scan is a scan where they inject a dye, and that dye goes to areas of higher metabolism. And if you recall, cancer is rapidly dividing and metabolizing cells, and so you'll get a concentration or a hot spot of PET scan dye in an area where there's a metastasis. Sometimes they will do sputum samples and analyze them for abnormal cells, and you can sometimes diagnose a cancer looking at a sputum sample. If you've got brain or bone mets suspected, they will do a brain scan and a bone scan. Usually, a diagnosis is confirmed with a biopsy via bronchoscopy, sometimes with percutaneous needle, and sometimes with a mediastinoscopy, and they get lymph nodes that way. Some tumors can't be reached with a bronchoscope, and so that's when they use a needle biopsy, but a bronch is a preferred method if at all possible. Sometimes if you can't reach the tumor with a bronchoscopy, you can do what they call a bronchoalveolar lavage, which is when they put fluid in the bronchoscope and lavage or wash out the lung tissue and then aspirate it back out, and then they'll look at the cells that are retained in that fluid for signs of cancer. Lung cancer therapy depends on the kind of tumor and on staging. So for small cell cancer, chemo is the treatment of choice, mostly because there are almost always mets at the time of diagnosis, and so you need a systemic approach rather than a targeted approach. Radiation is a more targeted approach, and sometimes they'll use it along with chemotherapy to shrink the main tumor, especially if the main tumor is causing symptoms like superior vena cava syndrome or pain in a certain region, or problems if it's a proximal tumor and the lung distal to it is collapsing. Sometimes they will shrink the tumor to open up those airways and keep more area open for gas exchange. There are new targeted therapies like monoclonal antibodies, anti-angiogenesis agents, and tumor growth factor inhibitors. And what these do, these are sort of biologics that do exactly what They say they do. Anti-angiogenesis agents, for instance, help to cut off the blood supply from the tumor. Growth factor inhibitors help inhibit the growth of the tumor. And so different kinds of chemotherapy other than what you would call the traditional chemotherapy. For non-small cell, you can achieve a cure with stereotactic radiation or surgery. So if you have a tumor that is localized, you can cut the tumor out, or stereotactic radiation is basically kind of like well, they call it a gamma knife in some places, but it's just targeted, almost a laser-like surgery where they go in and radiate a small area with a large amount of radiation in several doses. And what it does is it kills the tumor, and the tumor resorbs into the lung, and the dead tumor cells basically go into the airways and you cough them out. Surgery is only appropriate for a tumor or if you're taking out an entire lobe. Palliative surgery or radiation for comfort. I mentioned sometimes they'll debulk a tumor with radiation or surgery if you've got superior vena cava syndrome, or if you've got a tumor in an area that's particularly painful or causing pneumothorax. Chemo and radiation alone or with surgery are used for several different types of non-small cell lung cancer. Lots of different chest injuries that people can get. Fractured ribs are usually painful, but not incredibly serious, and they'll give you nonsteroidals for pain. Sometimes they'll tape them up, but they heal pretty much on their own. A flail chest is pretty serious. That's when you've got fractured ribs and your sternum is either fractured or your rib cage on one side is severed from your sternum, and your chest moves in two different directions at once. You can get penetrating wounds from either gunshot wounds, knife wounds, all kinds of different things. But one of the common denominators of chest wounds is either a pneumothorax or a hemothorax, and so I'd like to spend just a little bit of time talking about those. So hemo and pneumothoraces can be the result of blunt or penetrating injury to the chest wall. You can have a partial or a total collapse of one lung or of both lungs. So if you remember, the pleural space is an airtight compartment and it has negative pressure. The negative pressure allows for the tidal movement of air in and out of the lungs. So remember, you breathe in and the atmospheric pressure pushes the air in because you've got negative pressure in your chest, and then the exhalation, the negative pressure in the chest comes back and pushes the air back out. When you break that airtight compartment, that causes air to rush in at the site where the compartment has been broken, and that collapses your lung, and that's a pneumothorax. Pneumothorax is always a threat in chest injuries, the ones I just mentioned, broken ribs, flail chest, penetrating chest injuries. And it's also a threat after chest surgery. A pneumothorax can also occur spontaneously when there is a rupture of an alveolus, and this is called, interestingly enough, a spontaneous pneumothorax. Tall, thin people and smokers are more prone to spontaneous pneumothorax. Cases have also occurred after scuba diving, flying, or mountain climbing. It has to do with changes in pressure, atmospheric pressure. A pneumothorax may resolve on its own with rest and administration of oxygen to relieve discomfort. However, if the amount of air in the pleural space is minimal, a large bore needle may be used to aspirate it. When you have greater amounts of fluid or air, a chest tube insertion is necessary, and it's connected to water seal drainage to remove the air and allow for re-expansion of the lung. This illustrates the difference between the normal lung and a lung with pneumothorax. So you've got air in the pleural space where all that white space is, and it's collapsing the lung. There was looks like a rupture in the lung wall, and that's where the air came in. Or you can have a leak in the chest wall, and air can come in there. And as you can see, when the lung collapses, all those little alveoli also collapse, and no gas exchange takes place there. Some major concerns for a patient with any type of a chest injury include maintenance of an airway. That airway is always the most important. Assurance of adequate ventilation. Sometimes people require mechanical ventilation, sometimes they require supplemental oxygen, sometimes they can do it on their own. And also, you need to treat the circulatory problems to ensure circulation of oxygenated blood. So, for instance, if you have somebody with chest trauma who has also lost a lot of blood, you'll need to support their circulation with increased volume or maybe even a transfusion in order to have enough volume to carry the oxygen around to the rest of the body. Respiratory failure is defined as the inability to maintain adequate blood gas values. So this includes both oxygen and carbon dioxide, and it also, because of the carbon dioxide, includes the pH. So what you'll see is you'll see someone with profound hypoxemia, hypercapnia, and respiratory acidosis. This can occur because of inadequate ventilation, not enough air is getting in, poor oxygenation, you're not getting enough oxygen either in enough circulation for the oxygen and carbon dioxide to diffuse, or both. So inadequate ventilation, poor oxygenation, or both. Acute or respiratory failure has many etiologies. You can have an acute respiratory infection in someone with chronic lung disease. You can have a CNS disorder such as Guillain-Barré or ALS. You can inhale a toxic substance or aspirate a toxic substance. For instance, if you've been in a fire, smoke inhalation can often bring about respiratory failure. And then, of course, there is an opioid overdose. So we often talk about a change in level of consciousness as one of the first signs you'll see of hypoxemia. So look for restlessness, confusion, agitation, drowsiness. Drowsiness is also something that you'll see with hypercapnia as well. In your arterial blood gases, here's a little example here. You'll see a decreased PaO2. This is really decreased. You'll also see a decreased pH because you will have hypercapnia. Your carbon dioxide level will be increased. You'll also see someone who's very dyspneic, cyanotic, rapid, deep respirations with use of accessory muscles, trying as hard as they can to get as much oxygen as they can and blow off all of that CO2. So the diagnosis of respiratory failure is made based on arterial blood gases, usually a PaO2 below 60 or a PCO2 above 50. In chronic lung disease, a drop in the PaO2 of about 10 to 15 millimeters of mercury is what they look at, because if you recall, they carry a chronically low PaO2 to begin with. Capnography, they will measure the exhaled end-tidal CO2. For therapy, it's almost always high flow oxygen, BiPAP, remember, bilevel positive airway pressure. So you've got a little bit more pressure when you inhale, and then you have pressure when you exhale, and that's to keep those airways open so that there's more area for gas exchange available. Um, Sometimes people, a lot of times actually, people will be intubated and be on mechanical ventilation if they fail BiPAP. You always want to treat the underlying cause, whatever that is, whether it's an infection or an injury of some sort. Um, Interventions to improve airway clearance and gas exchange, positioning, uh, chest physiotherapy if they are able to, coughing and deep breathing, but they're usually not able to. And you want to be really careful with the use of sedatives. People who are very hypoxemic can be agitated, and anxiety can cause even more problems, but you want to be really careful with this because you don't want to depress their respiratory rate. A word about people with COPD. As you recall, people with COPD adapt to chronically high PaCO2s, and so their stimulus to breathe is a low PCO2, or excuse me, a low PO2, because their carbon dioxide is chronically high. So it's just like, in your nose. When you walk into a room and you smell something, pretty soon your nose adapts to it and you don't smell it anymore. Then you walk out of the room and then you come back in and you smell it again. Well, that's sort of like what your carbon dioxide sensors are like in your body. And so the sensors sense the pH in the blood, which is a reflection of the carbon dioxide, and that's your drive to breathe if you're a normal person. If you retain CO2, those sensors just kind of get shut off because they're used to it. And so then that person's drive to blood or drive to breathe is low oxygen. Well, if you give a person with COPD high flow oxygen, that will turn off their drive to breathe. Respiratory failure is the exception to this rule. You give people with COPD high flow oxygen no matter what. They're probably going to be on BiPAP or mechanically ventilated anyway. And so this is the one time where you can give high flow oxygen to somebody with COPD because they have respiratory support, and without it, they're going to die anyway. ARDS stands for adult respiratory distress syndrome or acute respiratory distress syndrome. It is an acute lung injury. It's a group of disorders that have diverse causes, but they have very similar pathophysiology, symptoms, and treatment. So what you can get is you can get this injury most often from sepsis, but it can also happen with pneumonia, trauma, shock, a narcotic overdose, inhaling irritants. It can happen with burns. It can also happen with pancreatitis and with aspiration. So a lot of different causes for ARDS, but the result is pretty much the same. And that result is an acute lung injury. The alveolar capillary membrane is damaged, and you get non-cardiogenic pulmonary edema. So all of the fluid that is in those cells, the alveolar cells, leaks out, and you get pulmonary edema. This can affect people even without a previous history of lung disease. So it's an equal opportunity disease. You don't have to have chronic lung disease to have it. This, of course, reduces gas exchange. The area for gas exchange is diminished because of the edema in the alveolar spaces, and this leads to hypoxia. And the atelectasis and edema can also cause hemorrhage of the lung tissue, which, as you might imagine, makes things worse. Prevention is the key here. Early recognition and treatment of the underlying disorder is the key to preventing ARDS. Here we have a comparison of a normal lung versus a lung with ARDS. What you see is a lot of edema. The hyaline membrane, which is basically the alveolar membrane, is damaged, and some of the alveoli are collapsed, some are distended. The whole thing is just a mess, and there's very little area for gas exchange, but the big thing to take home here is the widespread edema. Complications of ARDS are heart failure, infection if there wasn't an infection already, a pneumothorax, DIC, which is disseminated intravascular coagulation. We'll talk about that in the next unit when we talk about hematology and clotting. The mortality rate from ARDS is about 40%. This is not universally fatal, but it's got a high level of mortality. People can survive ARDS and they can recover completely. Um, Basically, how you diagnose it is history, physical exam. The chest x-ray is almost completely whited out, just as you see here. Um, just looks like a snowstorm, and that's just all edema. They also will do a chest CT, ABG, ECG to rule out a cardiac cause, because you can get pulmonary edema that looks like this from a cardiac cause as well. These are people who are always in the ICU. Of course, you want to treat the underlying cause, if it's pneumonia, if it's cardiac trauma, sepsis, whatever. They get positive pressure ventilation. As I mentioned, they have mechanical ventilation, and they're almost always intubated. Position is important here. You position the good lung down, or sometimes even prone, to allow for better perfusion. You need to use gravity where you can. And if both lungs are involved, the right lung has more surface area, so position them on the right side. Anything you can do to increase blood flow to an area that might get ventilation. And then just basically supportive care. These are some of the sickest people you will ever see. And honestly, I doubt that you'll see anyone in the Kindred ICU with ARDS, but you may take care of people at Kindred who have recovered from ARDS and who are still in the hospital continuing to recover.